All right. Well, let's go ahead and get started. I'm Adrian Hernandez, today's moderator for Collaboratory Grand Rounds, and really excited to have John Casey and Matt Precker here to talk about the device trial, an embedded pragmatic trial of emergency airway management. I think if anyone's taken a tour of the ER or other emergency settings, you know this is not an easy area to do research in. And so great to see this group coming together to share what they've done in the critical care setting of an important management issue. So we'll start off with John. So John, thanks for coming here and sharing what you all have done.
Well, thanks, Adrian, and the entire NIH Collaboratory for inviting us to speak today. As mentioned, I'm a pulmonary and critical care physician at Vanderbilt University Medical Center and the director of the Coordinating Center for the Pragmatic Critical Care Research Group. It's my pleasure to be here today to present the results of the direct first video laryngoscope device trial, along with my colleague, Matthew Precker. I'll present the background. Dr. Precker will present the methods and discussion, and then I'll come back on and discuss some of the challenges around conducting this kind of research. We have no disclosures that are relevant to this talk. This trial was funded by the Department of Defense. Emergency tracheal intubation is a common and high-risk procedure. Over 2 million critically ill adults are intubated each year in the United States. When elective tracheal intubation is performed in the operating room, complications are rare. When the same procedure is performed for a critically ill patient in the ED or ICU, complications occur in up to 40% of cases. Further, we know that we can do better. Failure to intubate in the first attempt occurs in up to 20 to 30% of intubations in the ED or ICU. And failure on the first attempt is associated with life-threatening complications. As shown here, those complications include severe hypoxemia, aspiration, and cardiac arrest. There are two devices that are commonly used to perform tracheal intubation, a direct laryngoscope and a video laryngoscope. A direct laryngoscope is a simple device composed of a handle, a blade, and a light. Using this device, an operator inserts the blade into the mouth, displaces the tongue and epiglottis, and creates a direct line of sight view of the vocal cords and trachea to aid in passage of an endotracheal tube, a technique that has not changed significantly in the last 70 years. A video laryngoscope is a similar device that has the same components, but also adds in a camera near the tip of the blade. This camera allows a better visualization of the vocal cords and allows what's called indirect laryngoscopy, in which an operator can obtain a view of the vocal cords without creating a direct line of sight passageway. This may increase the ability to obtain a good view of the vocal cords, but it may make it harder to then pass that endotracheal tube. Video laryngoscopes have been around for about 20 years, but it's worth noting that a direct laryngoscope remains the primary device, being used in 80% of ED and ICU intubations worldwide, and more than half of intubations of critically ill adults in the United States. Current guidelines for tracheal intubation state that use of either a video or direct laryngoscope is acceptable. There has been some prior research comparing video and direct laryngoscopes. However, that research has largely been single center and small trials, with the exception being one trial of 371 patients enrolled in French ICUs that showed no difference in successful intubation in the first attempt. We hypothesized in the device trial that use of a video laryngoscope would increase the incidence of successful intubation in the first attempt. The device trial was conducted by the Pragmatic Critical Care Research Group, a clinical trial network composed of emergency medicine, anesthesia, and critical care medicine providers who practice in the EDs and ICUs of 20 centers across the United States. And we focus on pragmatic trials comparing the effectiveness of emergency interventions. I'll now turn the presentation over to my colleague, Dr. Precker, who will present the methods and results of the device trial.
Hey, thanks a lot, John. My pleasure to be here. I appreciate the invitation from this group. I practice emergency medicine and pulmonary and critical care here in Minneapolis, Minnesota at Hennepin County Medical Center, and then led the device trial as the protocol chair. And I've worked with the Pragmatic Critical Care Research Group for a number of years. The design of the device trial was a multi-center parallel group unblinded pragmatic randomized trial where we compared the use of video laryngoscope with the use of a direct laryngoscope for tracheal intubation in critically ill adults. The device trial enrolled at 17 sites in the United States, including 7 EDs and 10 ICUs. All adults undergoing orotracheal intubation using a laryngoscope were enrolled, except for those patients who were known to be pregnant or a prisoner. Those who intubation was too urgent to perform the study procedures, and for those patients where clinicians determined that a video or a direct laryngoscope was required or contraindicated. And as a trial comparing two standard of care treatments during an emergency procedure, the trial was conducted under a waiver of informed consent, and an IRB-approved patient information sheet was given to patients and families participating after enrollment to inform them of their participation. Patients were randomized in a 1-to-1 fashion to video or direct laryngoscope use and permuted blocks of variable size stratified by trial site. The randomization assignment was concealed using opaque envelopes, and patients, clinicians, and research personnel were not blinded to trial group assignment after randomization. For patients assigned to the video laryngoscope group, the operator was instructed to use a video laryngoscope on the first attempt. A video laryngoscope is defined as a laryngoscope with a camera and a video screen. Our trial protocol didn't determine the brand of video laryngoscope or the blade shape. Those were selected by the operator. Operators were instructed to use the video screen when performing laryngoscopy and passing the endotracheal tube. For patients assigned to the direct laryngoscope group, the operator was instructed to use a direct laryngoscope, which we define as a laryngoscope without a camera or video screen. Trial protocol didn't determine the brand of direct laryngoscope or the shape of the blade, which generally is curved in a Macintosh style or straight in a mill. The trial protocol didn't specify any other aspects of the intubation procedure, including the type of laryngoscope on subsequent laryngoscopy attempts. Number of data points were collected for the study. Prior to randomization, the clinician performing intubation reported their subjective assessment of the anticipated difficulty of intubation as easy, moderate, or difficult. After randomization and during the procedure, a trained observer who wasn't involved in the performance of the procedure collected data on the primary outcome by recording the number of times the laryngoscope blade entered the mouth, the number of times a bougie entered the mouth if used, and the number of times an endotracheal tube entered the patient's mouth. They collected data on the duration of intubation, as well as the lowest oxygen saturation and blood pressure between induction and 2 minutes after intubation. Post-intubation then, the operator recorded the best laryngeal view they obtained while performing the procedure. They recorded the occurrence of any safety outcomes, including pulmonary aspiration, esophageal intubation, and injury to the teeth. And then they reported the number of prior intubations they had performed at that enrollment, by the time of that enrollment, including the number of overall intubations and the proportion of those prior intubations that were performed with a video laryngoscope. Finally, trial personnel reviewed the medical record to collect data on additional characteristics and clinical outcomes. The primary outcome of the device trial was successful intubation on the first attempt. For a secondary outcome, we selected a composite of severe complications that occurred between induction and 2 minutes after intubation, and those were severe hypoxemia, severe hypotension, new or increased vasopressor use, cardiac arrest, or death. To select a sample size for the device trial, we assumed an incidence of successful intubation on the first attempt in the direct laryngoscopy group of 80% based on prior experience in this network and published literature. With 90% statistical power and a two-sided alpha of 0.05, we calculated that we'd need 1,920 patients to be enrolled to detect an absolute difference of 5 percentage points between groups in the incidence of our primary outcome. Assuming a missing data rate of up to 4%, we plan to enroll a total of 2,000 patients in the device trial, 1,000 per group. We analyzed the primary outcome using an unadjusted intention to treat comparison of successful intubation on the first attempt with a chi-square test. We also pre-specified a single interim analysis that would occur at the halfway point of the trial after enrollment of 1,000 patients. The Data Safety Monitoring Board was allowed to stop the trial or recommend stopping the trial For efficacy, specifically, if a p-value of that chi-square test was less than 0.001 at the halfway point. And indeed, after enrolling patients for approximately 8 months, on November 17th of last year, at the time of the pre-specified interim analysis, the Data Safety Monitoring Board recommended that trial enrollment be stopped because the pre-specified stopping criteria for efficacy had been met. I now want to pivot a bit and tell you about the results of the device trial. We'll start with the flow of patients through our trial. Over this 8-month period of time between March and November 2022 at these 17 sites, nearly 2,000 patients were assessed for eligibility for the device trial. 73%, or 1,420 patients, were randomized in the study. I want to highlight some of the exclusions that were accrued in this study. Expanding that box, then, you can see that approximately 20% of patients met one or more exclusion criteria. A very small number of patients, 82, or 4% of all patients screened, were excluded because the operator felt a video or direct laryngoscope was required, meaning they didn't have equipoise for this clinical question. Uh, 1,420 patients were randomized in the device trial, and I'm going to expand that box next to show you some details. 707 patients were assigned to the video laryngoscope group, 713 to the direct laryngoscope group. Of those patients, 3 patients in total were excluded after randomization because they were discovered to be prisoners. That left us with 1,417 patients in the primary analysis. I'll next spend a couple of slides showing you characteristics of patients, the clinicians performing the procedures that we refer to as the operators, and the characteristics of the intubation procedure. Overall, baseline patient characteristics were similar between the 2 trial groups. The median age of our patients was 55 years, 35% were female, and the median body mass index was 27. You can see the most frequent indications for intubation: altered mental status in 45% of patients, and acute respiratory failure in approximately 30%. And 70% of patients were intubated in the emergency department. The pre-randomization subjective assessment of intubation difficulty, anticipated difficulty, was moderate or difficult in over half the patients. Likewise, the characteristics of operators in these trials were similar between groups. These operators had performed a median number of prior intubations in their practice or training of 50, with an interquartile range of 25 to 92. Over half of study intubations were performed by operators with comparable prior experience using a video and a direct laryngoscope, which we define as the proportion of prior intubations between 0.25 and 0.75. And 91.5% of procedures were performed by an emergency medicine resident or a critical care fellow. Presenting to an audience like this that are experts at pragmatic clinical trial design and oversight and conduct, this is a slide that we're especially proud of. You can see here that we have excellent adherence to the randomization assignment and therefore separation between groups. On the first laryngoscopy attempt, a video laryngoscope was used in all 705 patients in that group. A direct laryngoscope was used in 99%, or 704 of 712 patients in the direct laryngoscope group. As we get closer to showing you the primary outcome, I want to highlight an intermediate outcome of tracheal intubation, and that's what view the operator obtains of the vocal cords during laryngoscopy. This grade or quality of laryngeal view is graded using the Cormack-Lehane system, where a grade 1 view is a view of most or all of the vocal cords, whereas a grade 4 view is a view where you see an epiglottis only or sometimes no anatomy, an unfavorable view. Focusing just on grade 1 view, the most favorable, you can see there's a substantial difference between the video and direct laryngoscope groups. Grade 1 view is in 76% of laryngoscopies in the video laryngoscope group and 45% in the direct laryngoscope group. And these data similar to these have been reported in prior observational and randomized studies, so it's not a new finding. But what we really wanted to focus on and what I care about when I intubate patients in the ED or ICU is how quickly and successfully could I intubate the trachea. So I'll show you those data next. Our primary outcome, a successful intubation on the first attempt. In this clinical trial where we enrolled over 1,400 patients over an 8-month period of time, occurred in 85.1% of those in the video laryngoscope group compared to 70.8% in the direct laryngoscope group. And that was an absolute risk difference of 14.3 percentage points and a p-value of less than 0.001. And importantly to the clinicians in our network, what we saw was essentially a halving of the rate of failure on the first intubation attempt with video laryngoscope use compared to direct laryngoscope use. Here we reiterate the results of the primary outcome, the device trial, and here plotting it as cumulative incidence curves with 95% confidence intervals. Those are shown, that incidence is shown on the y-axis, and that's the percentage of patients who experience successful intubation on the first attempt. On the x-axis is the time elapsed between the start of laryngoscopy and successful intubation. So you can see that effect size of 14 percentage points in first attempt success, and video laryngoscopy resulted in faster time to intubation by a median of about 8 seconds. We performed subgroup analyses, which are shown in this forest plot. The subgroups we chose to analyze included the location in the hospital at the time of intubation, body mass index, whether the patient suffered an injury prior to intubation, the anticipated difficulty of intubation, and then 2 subgroups, which I'll highlight in just a moment, that have to do with operator experience, the total number of intubations, and the proportion of those intubations performed with the video laryngoscope group, with the video laryngoscope. As you can see, all subgroups favored video laryngoscopy compared to direct laryngoscopy in terms of the primary outcome, first attempt success. Highlighting the operator's number of prior intubations, which we categorized as less than 25 prior intubations, 25 to 100, and greater than 100. This subgroup suggests that operators experience the most benefit, operators who experience the most benefit from video laryngoscopy were those with the least overall experience. And showing the actual point estimates here, you can see that even in patients with the most prior experience, having intubated over 100 times, they still did better with the video laryngoscope group by an absolute difference that was greater than the overall difference we sought to find in the trial as a whole. Let me show you that last subgroup now, just to highlight that even for the most experienced VL, or video laryngoscopy, was superior to direct laryngoscopy, even among operators who'd done more than 75% of their prior intubations using a direct laryngoscope. We captured several exploratory procedural outcomes in this trial. They're shown here by trial group. The duration of intubation was a median of 38 seconds in the video laryngoscope group and 46 seconds in the direct laryngoscope group. The reason for failure on the first intubation attempt, as reported by the operators, was an inadequate view of the vocal cords in 17% of patients in the direct laryngoscope group compared to approximately 4% in the video group. Whereas the failure due to an inability to pass the endotracheal tube or a bougie occurred in similar percentages of patients in both groups. The secondary outcome of our trial was this composite of severe complications, which occurred in a total of 21% of patients in the video group and 20.9% of patients in the direct group. The incidence of each severe complication were similar between groups. These are the safety and exploratory clinical outcomes of the trial. The safety outcomes of aspiration, esophageal intubation, and injury to the teeth were rare overall and approximately the same between groups. And then the number of ICU or ventilator-free days and mortality did not differ by trial group significantly. So I want to summarize the results of the device trial and then hand it back over to Dr. Casey to discuss these findings and some of our approach to designing and conducting the trial. The device trial was a 1,417 patient randomized trial in 17 EDs and ICUs in our network in the United States. We found, we think importantly, that a video laryngoscope increased successful intubation on the first attempt by 14 percentage points. Some of this importance comes from the fact that failure to intubate on the first attempt can result in increased incidence of life-threatening complications. And then the landscape of tracheal intubation in the ED and ICU still currently is dominated by direct laryngoscopy. And we hope that the device trial published in print at the New England Journal of Medicine just last month moves the needle a little bit in that regard. But I'll turn it over to John for further discussion on the trial.
Great, thanks, Matt. So as Matt just mentioned, the device trial showed a 14.3 percentage point difference between the groups in the primary outcome of successful intubation on the first attempt between a video and direct laryngoscope. And that equates to a number needed to treat of 7 patients. So for the next 7 ED or ICU patients undergoing intubation, 5 patients could be intubated with either a VL or a DL on the first attempt. 1 patient couldn't be intubated on the first attempt with either device, and 1 patient would be successfully intubated on the first attempt with a VL, but with a video device, but not with a direct device. This is a relatively large absolute difference, perhaps larger than you might have expected. I think it begs the question, why did it take 20 years to prove that VL was superior? It's worth noting the number of patients we're talking about. During the period that VL was available before the device trial, 40 million critically ill adults in the United States were intubated with either a video or direct device. There are many potential explanations for why it took so long for a definitive study to be conducted. Those explanations include confounding by indication, improvement in technology of the VL device, increased comfort and experience with VL laryngoscopes. None of those might explain why prior observational studies haven't shown this difference, but it doesn't explain why a large definitive trial wasn't conducted until now. There are many challenges to conducting randomized trials of emergency procedures in critically ill patients. About 2 years ago, Matthew Simmel and I spoke to this group about those barriers. We reviewed 4 major challenges, which include the brief therapeutic window for emergency and critical care interventions, in which the window for enrollment is measured in minutes or hours, not days or weeks. The fact that critically ill populations are complex and commonly have acute and chronic conditions which limit the time available to phenotype patients and result in low signal to noise ratios, requiring very large sample sizes to detect small but important treatment effects. The under-recognized dilemma that patients may respond differently to the same intervention. The trials have historically been interpreted based only on the average treatment effect. And finally, the classic challenge for all emergency research among critically ill patients, which is that patients commonly lack decisional capacity and surrogates are frequently unavailable during the short window for intervention. I'd like to revisit this 4th challenge now in the context of the device trial. Shown here is an overview of the current regulations for informed consent in the United States. The y-axis represents the risk to patients of participation in research. Things on the top half represent research that presents significant risk to patients. And things on the bottom half represent research that presents no more than minimal risk to patients. The x-axis represents the ease with which consent can be obtained. Things on the left half of the graph represent research in which consent can be easily obtained. And things on the right represent research in which consent is infeasible. Regardless of the risk to patients, the current regulations require that consent be obtained when it can be obtained. The type of research we're discussing today is where consent is infeasible. And for this type of research, there are only 2 mechanisms to conduct research: exception from informed consent and waiver of informed consent. I want to spend a few minutes on each of these. Exception from informed consent was implemented in 1996 to standardize the approach to research in emergency settings and procedures. The goal of EFIC is to demonstrate transparency and respect for persons when the window for intervention is too short to allow prospective informed consent. It only applies to research for conditions that are life-threatening, in which existing treatments are unproven or unsatisfactory, and the research involves more than minimal risk. There are many components of EFIC, but we'll highlight the 3 that are most distinct from other types of research. Because prospective informed consent is infeasible in these trials, EFIC requires that investigators complete community consultation and public disclosure prior to the initiation of research procedures. Community consultation is a process of 2-way communication with community members, with the goal of allowing affected communities to provide meaningful input to investigators in the IRB. It commonly includes activities like town hall meetings, focus groups, and one-on-one meetings with community leaders. It's a deep but narrow form of communication in which a small number of people are provided with significant information about the study and provide their feedback. Public disclosure, by comparison, is a process of one-way communication from investigators to community members with the goal of maximizing transparency. It commonly includes activities like press releases and radio, social media, and newspaper advertisements. It's a broad but shallow form of communication in which a large number of people are provided with a small amount of education with the goal of making them aware of the trial's conduct. These are important and noble efforts for trials that present new risk to patients that they would not experience as part of routine clinical care, especially for trials like trials of new drugs and new devices. But it's notable that these efforts are slow and costly. It's been estimated that it takes 1 to 3 years and $50,000 per site to complete the community consultation and public disclosure processes. Finally, trials conducted through EFIC require FDA oversight through an investigational new drug application, even if the studied therapy is commercially available and commonly used for in the condition being studied, which is within approved populations and indications. If EFIC is intended as a way to standardize and facilitate emergency research, how's it doing at that goal? Shown here are the number of trials published in the 20 years after the EFIC regulations were implemented. A total of 41 trials were conducted. Of these, 26 were new drug or device trials, the type of trials for which EFIC was most clearly envisioned. Only 14 trials, fewer than 1 per year, were comparative effectiveness trials like device, evaluating therapies that were in routine clinical use. It's important to contrast these research efforts to the research conducted during COVID-19. In the first 18 months of the pandemic, more than 11,000 trials were registered and initiated. When you compare that to the 14 comparative effectiveness trials in the first 20 years of EFIC, it raises concerns that the time and expense of EFIC may be preventing potentially beneficial research. For trials like device, where patients are unconscious and the procedure is emergent and consent is infeasible, there are only 2 methods of conducting the trial: EFIC or waiver of informed consent. Shown here are the criteria for waiver of informed consent, which include that the research involved no more than minimal risk to patients. It could not be carried out without the waiver. It only uses identifiable private health information if such information is required to conduct the study. It does not adversely affect patients' rights or welfare. And whenever appropriate, pertinent information is provided after participation. Of these, the criterion that gets the most attention is the determination of minimal risk. And I think this determination of risk to participants has to be interpreted in the context of the risk of clinical care. When a patient in clinical care presents with a common condition with at least 2 available therapies, if there's evidence that one therapy is superior for the patient, it's easy. We give that therapy. When neither therapy is known to be superior for the patient, a choice still has to be made. And in current clinical practice, that choice is made arbitrarily. Some clinicians give therapy A, some clinicians give therapy B. That decision may be based on things like training patterns or hospital formularies. But patients still experience the unique benefits and risk of those 2 different therapies, and nothing's learned from this interaction, and the care of future patients is not improved. Some people have posited that this type of arbitrary variation, in which different clinicians are choosing different treatments for the same patient, represents clinical equipoise. You can imagine a different structure in which that same decision is now made in a structured way through comparative effectiveness research, so that when neither therapy is known to be superior for a given patient, that choice is made randomly. The patients experience the same risk and benefits of the 2 therapies, but knowledge is gained and the care for future patients is improved. Many bioethicists have posited that when 2 interventions are commonly used in clinical care and neither is known to be superior, having the choice between the 2 be made randomly rather than based on arbitrary factors unrelated to knowledge of which therapy is best for a given patient may represent no more than minimal incremental risk compared to the risk of routine clinical care. Currently, there are ongoing debates about trials like device, pragmatic trials comparing commonly used interventions during emergency care in which consent is infeasible. There are controversies regarding which form of regulation should be applied. These discussions are often academic and esoteric, and I think it's helpful to look at real-world examples. And we have a nice comparison within our own network. So concurrently, the Pragmatic Critical Care Research Group has been conducting 2 trials. The device trial, which compared direct versus video laryngoscope use that was presented today, and the RSI trial. The RSI trial evaluates another important question during emergency tracheal intubation, which is the ideal sedative, for which ketamine and etomidate are the two most commonly used sedatives in current clinical practice. The device trial was conducted with a waiver of informed consent, and the RSI trial with an exception from informed consent. In both trials, the IRB reviewed and approved the study prior to initiation. Because the RSI trial was conducted under EFIC, it also required a process of FDA review through an IND and a prolonged period of community consultation and public disclosure. In both trials, patients are notified of their participation following enrollment. In the device trial, this occurs through an IRB-approved form provided by clinicians. In the RSI trial, it occurs through an IRB-approved form provided by the research team. Patients have been accepting of both trials. In the device trial, none of the 1,420 patients withdrew from the trial. In the ongoing RSI trial, only one of approximately 400 patients have withdrawn. I would argue that both trials are providing robust patient protections and that patients have been accepting of both trials. But there are significant differences in the way these trials have been conducted in terms of time, cost, and effort based on the regulatory pathway used. The device trial was completed in less than 1 year. The ongoing RSI trial is expected to require 8 years to enroll a similar number of patients. The device trial was completed with a budget of $1.5 million. The RSI trial has a current budget of $9 million. Further, I think it's worth highlighting that neither regulatory pathway truly fits pragmatic comparative effectiveness research. Waiver of informed consent regulations were really envisioned for observational research, and there's no clarity in the guidelines regarding how we define minimal risk and in what circumstances, if any, a waiver of informed consent is appropriate for pragmatic RCTs. Further, when conducting interventional trials through a waiver of informed consent, there's no standardization to how patients should be notified of their participation. For EFIC, EFIC was envisioned for trials of new drugs and devices in emergency conditions like cardiac arrest, not for comparative effectiveness trials that would require thousands or 10,000s of patients. Further, EFIC is narrowly written to apply to life-threatening conditions, and there are many important conditions that are not immediately life-threatening, but for which consent is infeasible, conditions like severe agitation and alcohol withdrawal, for which the current regulations do not have an easy way to conduct the trial. Finally, community consultation and public disclosure, as noted, are prohibitively expensive and time-consuming and require expertise not available at most centers. And using this pathway severely limits the number of comparative effectiveness trials that can be completed. I want to thank the NIH Collaboratory for helping to draw scrutiny to this issue. Shown here is information from their website where they discuss the complexities of waiver and alteration for pragmatic trials. And shown on the right is a recent editorial from the American Journal of Bioethics written by Robert Califf, the FDA commissioner and members of the NIH Collaboratory, where they highlight this gap in the regulations, stating that neither HHS nor FDA regulations currently have guidance on whether or when pragmatic trials might be categorized as minimal risk. And these issues need the joint attention of federal agencies, the research community, the healthcare delivery ecosystem, and patient advocates. I want to end by saying I think there's really a moral imperative to figure this out. We have to develop an ethical and regulatory framework for pragmatic comparative effectiveness research. And the fact that there isn't agreement, I think, is limiting the number of trials that are being conducted. I'll highlight a quote from Ruth Faden, a bioethicist who's written a lot about learning healthcare systems and pragmatic trials. She states that insofar as contemporary research ethics and oversight interfere with learning activities that could reduce errors and improve clinical effectiveness, the overprotection itself is a source of harm to patients' interest. And when thinking about trials like the device trial, I think rather than thinking within the current binary framework of minimal risk versus not minimal risk, I think they should be compared to what's happening in current clinical care. So in the last 20 years, more than 20 million critically ill adults were intubated with a direct laryngoscope. And if the lack of a regulatory framework had prevented the device trial from being conducted, 1 million critically ill adults each year would continue to be intubated with a potentially inferior device indefinitely. So in conclusion, I hope that we've shown that among critically ill adults undergoing tracheal intubation in an ED or ICU, the use of a video laryngoscope increased successful intubation in the first attempt compared to use of a direct laryngoscope. and that there's a moral imperative to develop an ethical and regulatory framework for comparative effectiveness research like the device trial. I want to thank the members of the Pragmatic Critical Care Research Group for their help in answering important questions like the device trial, and thank the NIH Collaboratory for the invitation today. Really looking forward to the discussion.
All right. Well, there's a number of comments here we'll get to. And so thanks for a great presentation and a great study in a challenging area. So I guess first off, let's see if David Jensen, if you want to unmute, some of your question may have already been answered, but it would be good to hear what your thoughts are here. And
yeah, so apparently you did a complete waiver, did the research because you're effectively one and done. You're intubating and maybe collecting a little bit of clinical information afterward. But what you then did is provided them with an information sheet, letting them know they were in a clinical study, and that this is what was happening and so forth. So that all sounds really fine, and you explained why you went that path. So my real question then is, why did RSI follow a different path?
Yeah, it's a great.
I could easily argue that the two drugs are equivalent. You're using standard of care, and all you're going to do is an effectiveness research study using these two standard of care drugs.
Yeah, that's a fantastic question, and you're exactly right that I think that this is a clear case because patients are showing up for an emergency procedure that cannot be delayed by even a minute, and the procedure takes 2 minutes. So there's clearly not an opportunity for prospective informed consent in this pathway, and that when you're notifying patients afterwards, the trial's over. The trial intervention's been delivered, and the primary outcome data has been collected. So there may be more complexity to trials that have ongoing interventions, but this is not one of those examples. Your question regarding the RSI trial is that the FDA regulations for waiver of informed consent had not been aligned with the OHRP. They recently have been. So in the 21st Century Cures Act, they updated the FDA regulations to allow for waiver of informed consent, but they have not yet provided clarity with regard to how they plan to use those regulations. So we discussed doing RSI under waiver, and actually asked the FDA not about the waiver, but if the trial would require an IND if conducted under a waiver, and they responded that the trial could only be conducted under EFIC. So they have stated that they'll defer decisions to local IRBs regarding the determination of minimal risk, but when we asked them a specific question about this study, they answered a question we didn't ask about the mandating that it be done under exception from informed consent. So RSI would have been done, I think, 5 years ago, had we done it under waiver, and instead it's taken 8 years and 7 times as much money. And I would argue that I'm not sure how much extra patient protection has been provided through that process.
Yeah, agreed. Thank you.
Can I follow up on the question about kind of consent? So like in the various collaboratory trials where there's kind of an emergency setting or a semi-emergency setting, an approach is, for in the context that's well confined, such as a critical care unit, that every person who walks through there is essentially notified that there is a research study that's happening, and they can opt out if they ever were. What were the considerations around that? And corollary question is that, while we often think about emergency as like, within a minute, often these patients are declining over many hours. And so actually we have some, they get on the list of like, hey, here's someone we're really watching, and we may need to intubate. So 2 questions for you.
Yeah, I think you're raising the exact kind of questions that I think need to be addressed with guidance in the regulations. So you're asking that when a trial is ongoing that is being conducted with a waiver of informed consent because prospective informed consent is infeasible, how should patients be notified of the trial and be provided with the opportunity to opt out? And that's easier in interventional trials like this one that are at the patient level. So there's a clinician who's involved in study procedures and has the opportunity to notify patients. It might be harder at an intervention that's at the cluster level or the full hospital level. And I think that we need to have guidance around what format we should use for notifying patients. Is it always required to notify patients if there's a large cluster randomized trial at the hospital level. I don't think that's currently occurring in many studies. At the patient level, you have an opportunity to do so, but should that be done through patient level notification like we did in device, which is close to what is done in EFIC trials, or more general notification to patients, to every patient in the ICU or every patient in the hospital? And I personally think that we need to get stakeholder engagement to answer those questions. I think that there has been enough work done to suggest that patients would like to be notified of ongoing research, but the format in which that notification occurs, I think, needs further methods work and clarifications in the regulations.
Hey, all right, let's go to Karita. You've been pretty active on the chat here, so
Two whole comments, yeah.
You got a lot of questions, I understand. So
yes, well, first I just want to say thank you for doing this. As someone else who's an emergency physician and trying to do pragmatic trials in this environment, I'm just know how challenging it is. So thank you. I guess I've wondered this. I've been in practice, I was in residency 20 years ago, so I've seen the evolution of this over time. I think it's great that you finally have an answer, but I guess my worry is about the generalizability, and I may be completely wrong. I probably am, but I'm trying to understand in the health systems, like in the majority, you said two things that prompted my interest. You said the majority of emergency intubations are done using DL nationwide. I thought you said that. Which rings true because most people are not being intubated by residents. They're mostly in places that probably have anesthesia or something like that. And so then how does that what do you think I guess the results would be, given most of your intubations were by trainees who are very facile in, video, anything with video, and those of us who've been in practice for 20 years, not so facile with it and are more comfortable probably with DL. Because what I saw at the end of residency, some of the residents would say, oh, I want to do this intubation with DL because I've never done it before. Like, I just want to try it. So I guess I'm worried that like the difference was really just the comfort of the operator. And I was curious, I guess the second question is, if you did this in some place like HCA, like a community network of hospitals, do you think the results might be different? I'm assuming you're going to say no, but yeah.
Matt, take this one, and we have a slide about this question as well, since it's one that we receive all.
Yeah, thanks, John. I'm happy to share my thoughts. I think that this is a fascinating question that really resonates with my practice every day as someone who primarily supervises trainees and teaches relatively novice operators to perform this critical procedure. I think our trial results don't directly apply to operators that have intubated thousands of times. They didn't intubate in this trial. 97% of intubations in the device trial were performed by people with less than 250 prior intubations. So we kind of summarize that idea in this slide. How do these apply to operators with more or less prior intubating experience? And based on our subgroup analyses, the novice operator, someone that's intubated less than 25 times, the results of the device trial in that subgroup suggest that the number needed to treat to prevent one first attempt failure is 3 to 4 patients in that group. So that's a big benefit. And I'll just share my own anecdotal experience that training resident physicians to perform intubation in the real world, I think they need to understand the anatomy and how manipulations of the laryngoscope change the view and change the likelihood of success. And having that beautiful view with the camera and the screen really helps them maybe in the first 15 or 20 intubations. And then it may be time to transition to doing some where the supervisor is looking at the screen and the operator is looking in the mouth. So that's one strategy you might take, training these novice intubators. And then likewise, late career intubators, those who've done it thousands of times, device might not apply to that population, but it may be an open question, because the last thought I'd share is that in the community, so to speak, when emergency physicians, intensivists, and others are called on to perform intubation, at least we know based on emergency medicine studies, community emergency physicians may intubate once every week or once every 2 weeks on average. And so It's an open question of, are their skills the same as they were the day they left residency? So this learning curve issue is fascinating. We've got to limit our generalizability and impact of the device trial to the population we studied, but I think it is a little bit more generalizable than that.
And
John,
I'll
any
make
other
a
thoughts?
couple comments. Yeah, thanks, Matt. I'll make a couple comments. One is that, even among the people in our trial who had more than 75% of their prior intubations with a DL, VL was better. So I think it's an open question that amongst people who've done thousands of prior intubations who aren't well represented in our trial, the results of this trial may not apply. I think you're right about that. I think the same criticism has been raised for landmark guided central lines, that initially there was this pushback that I don't need that tool. And that may be true for the people who have already achieved competence with thousands of prior procedures. That's actually not who's doing the majority of procedures, it turns out. That our trial doesn't mandate that these procedures be done by trainees. And we have sought out some places that I think most people would consider to be community sites, but they're still high volume sites that have lots of capabilities in large ICUs. And even most community sites have training programs. So it turns out that at large sites, large hospitals that have large ICUs, and especially hospitals that have trauma programs, the majority of patients are being intubated by trainees. And the answer is very clear in that population. And then further, even if the results don't apply as much to people who've had thousands of intubations, well, everyone has to go through a learner phase. And it's pretty clear to me, based on the results of this trial, people should be going through that learner phase with a device in which they're likely to do much better. And in device trial, novice operators with a VL were as good as people who had many years more experience with a DL device. So I think it's hard to, I think you raise a great questions, and I think that you make some comments that I think are likely true, that there are people who probably have done thousands of intubations and are welcome to keep using a DL. But I think for the majority of operators, for our sickest patients, it makes sense to use a video device going forward.
Thank you. I just one follow-up. I promise I'll stop talking soon. One was, I was really curious, you said anesthesia was a big, anesthesia trainees did a lot of these. Was that in the more community sites where there weren't emergency medicine residencies?
The anesthesia operators were largely within the ICU intubations, which were about 30% of the trial, and they are admittedly the least represented group. So this was primarily emergency medicine and pulmonary critical care operators. And we have a number of anesthesia units, but they historically been lower volume units that contribute a smaller number to the trial.
Got it. Okay, that's what I figured, they would be in the ICU. And then my final question is, do you believe that residents have really done 100 to 250 intubations? That's my final question. That seems like very high for emergency medicine. Matt, that's for you. Do you believe it?
I do believe it. Yeah, the question we asked was, lifetime intubation experience. And so they may be thinking back to medical school anesthesia rotation, perhaps. But I think certainly our operators who are third or fourth year emergency medicine residents or fellows could definitely reach those numbers, and they do in our program here at Hennepin.
Great, thank you.
All right. Well, I want to pick on Pearl O'Rourke. So she's been leading our core for regulatory and ethics and IRB issues, and has many years experience in IRB. And Pearl, can you comment on the consent issues? Why haven't we figured this out? The guidance, everyone agrees there should be guidance, but why don't we have that, or what should it be?
I'm not going to take the blame for that. First of all, congratulations on a fabulous study and a fabulous presentation. As a recovering pediatric ICU doctor, believe me, visualization of cores on a 2-kilo baby is problematic. Anyway, I think you very well covered the difference between ethic and waiver of consent, and I think highlighted the issue that minimal risk is so key to that, which way you go. And I think there's controversy by some people. Does randomization push you over into different risk categories? I think most do not agree with that. And I think you well stated that you're looking at 2 routinely used, and the addition of research risk really is nil I mean, then remember that when you're looking at minimal risk for research, you're really looking at what is the added risk by doing the research. It's not, the intubation itself is probably a high risk procedure, but it's which way you're going on that. The issue of notification, we recently, a number of us on the ethics core did a study looking at a number of the protocols that have gone on with a waiver of informed consent and looked at what kind of notification was done. And it is fascinating. I mean, it goes everywhere from a direct letter saying, this is what we're doing, as virtually all of the items of a regular informed consent. If you want to opt out, send us this pre-stamped postcard. To the other end of the spectrum, a poster that says, we do research in this institution. If you'd like to opt out, call this number. It says nothing about the specific research, and then everything in between. And, after looking at this, we came out with a statement saying we think the default should be to notify people afterwards with justifications for when you should not. But I do think we need a lot better guidance on when and how to notify. I mean, there's huge logistics when some of these studies have, thousands of patients in, 50 settings. How do you, in fact, notify there? So I don't really have the answers. I think this is something that OHRP is looking at, particularly in comparative effectiveness research, and it's something that the Ethics and Regulatory Core is diving into actually right now at the moment, trying to better understand, why do people agree to be in research? Why do they opt out? And I think all of that would inform how to notify. So I really thank you for a fabulous discussion.
Pearl, can I just one other follow-up, and I'll also be interested in John and Matt's comments here. But I mean, it seems striking that this study helps support the needs for these types of studies where in the acute settings or semi-acute settings, that is simpler for people to be part of, especially when the results are, change or can change standard of care. So, because as I understand it, the practice here is highly variable and not necessarily so-called equal 50-50. So this does shift things. So, but does that help, like having more studies like this?
Yeah, I do. And as I'm sitting here, I'm thinking this needs to be a presentation given to OHRP, the Office of Human Research Protections, which is kind of the federal mothership for IRBs. And that I think it really, the comparison you had between the RCI and the directed versus video intubation, that speaks volumes. And yes, it was done at a time before FDA harmonized, which actually gives you very good data for comparing the two approaches. Painful, but good data. I would really suggest going to OHRP. And I would be happy to introduce you to the, help you get in touch with people there. But I think this does help, Adrian.
Yeah, because John and Matt, like as I understand it, like, the most common practice is direct laryngoscopy. And so what you find is actually the opposite should be done in terms of actually using video more commonly than currently.
Mm-hmm.
Yeah, I think that's right. And I'll say, Dr. O'Rourke, that first, I'm very glad that you're going to solve the challenge of who should be notified when for us. Because
yes, stay tuned.
Secondly, we'd be happy to do that. We'd be happy to make this argument in front of anyone who'll listen. And that's part of our passion about this work is convincing people that this is the right way to do this work and that this work is ethically mandated. And when we talk to patients, we talk to obviously thousands of patients after we enroll them, and we talk to patients through the community consultation process. And even for our waiver of consent trials, we have community consultation studios and patient stakeholders that we meet with. And the response is interesting in meeting with them. The meetings almost always go the same, which is it takes a while to convince them that there's clinical equipoise. They have trouble believing that we don't already know the answer. They say, well, I want my doctor to do what's right. And when you actually say, well, just so you know that I'm the doctor for lots of patients up here and I don't know the right answer, and the agent I use in every patient is different than my friends using 3 floors down in every patient, then they get angry, not about the research, but that it hasn't been done already. So patients, I think, don't understand that we have this kind of variability that's arbitrary and that it goes on for decades and exposes millions of patients to potentially inferior therapies. And when they understand that, they say, of course, you've got to do this research. I can't believe you haven't done it already. And so I think that's the framing that I think is sometimes missing from this conversation, is that these are risks that patients are already experiencing, and that the biggest risk is not figuring out which therapy is best for patients in the long term.
I couldn't agree more, but it's hard as an institution to say, well, we're really not sure why we do what we do, but we try our best. I mean,
Well,
not a big
actually, Pearl and me, I'll ask this question to John and Matt, and Pearl, you can opine as well. But this is kind of in honor of the FDA commissioner, since she quoted the good Dr. Califf and collaboratory alum. Question to you all in critical care. What do you think of the proportion of decisions you have to make like this that can have impact on survival or other outcomes that are done with judgment without clinical trial evidence? Is it 20% or 80%?
I would say that it's not that the therapies have no data behind them, but every therapy has additional questions for which there's no evidence, and I would say it's the majority of those decisions. So that's why we're doing this work, is that you come to work every day and try to figure out what's best for your patients, and you quickly realize that what you're doing is different than the guy across the hall, and that neither of you knows which one's right. And I'll say that my research colleague in this, Matthew Semler, who helps to lead the Pragmatic Critical Care Research Group, has a slide on this just highlighting that almost every decision we make has research gaps for which people are doing it differently. And in the last 10 years, we've done 20 trials like this with 50,000 patients. And it's not like we're running out of ideas. I think there are many more questions even within our specialty, and I think other specialties need to take a similar approach to their questions.
And I just add that a lot of us, our teachers are, we all were learners in the past. And I think when trainees ask me, well, why do we do it that way? Or why do you practice that way? A lot of those questions don't have evidence-based answers. And they're very simple things, clinical issues or treatments or equipment that we use every day. And so this kind of work is something we're sure passionate about in the network, and love the enthusiasm for figuring out the regulatory hurdles in this group.
I'll make one final comment, and I know we have to end, which is I know that Matt Semler is poking me in the chat to reference that for this 2-minute procedure, where 1 in 25 patients have a sudden cardiac arrest, which is about the highest risk thing we do in the ICU, there's huge variability in how it's done. And when we started doing this work a decade ago, there had only been 2 trials enrolling only a few hundred patients to help us figure out the answers to this for this procedure that's done millions of times every year. So I think clearly there needs to be more work in this space.
All right. Well, just quickly in 30 seconds or less, what's the next big question that you are aiming to address? Yeah.
We have the ongoing RSI trial. We have another trial that will finish next month, comparing the forms of pre-oxygenation, non-invasive ventilation versus face mask oxygen, and a trial that just finished comparing empiric gram-negative coverage, Zosyn versus cefepime. So maybe we'll have the chance to come back and talk about some or all of those down the road.
All right. And Matt, anything else to add? Like, what's next?
No, I'm excited about those results too. I think in this space around laryngoscopy and tracheal intubation in the emergency setting, now that we know that the video laryngoscope group is superior in our trial, I think the question is we need to drill down a bit and say, are there differences between brands or shapes of video laryngoscopes that are in widespread use? And does that impact patient outcomes? So I think we're going to focus some energy on trying to guide comparative effectiveness within the video laryngoscope group in future airway trials.
All right. Well, terrific session. And so we will have you back. We will have to learn more from what you all are doing, and then seeing how you're solving the different issues. So thanks so much. And hope everyone enjoyed today's Grand Rounds. Please join us next week. We'll have a really interesting session around financial incentives on how to eat healthier, perhaps, and making food choices. So this should be a fascinating discussion, especially as people are really thinking about issues regarding food as medicine and how that can be more preventive health approaches. So everyone have a great weekend, and thanks everyone for joining.